thanks to all the speakers. So you pass the question to me, and I will pass it to the room, or I will. We have time for a couple of questions, and I'd rather have them from the room. I have one or two questions if no other question raises, but so please. Yes.
Very interesting talks, a lot of overlaps. One of the central questions is not just children or students versus everybody else, but whose preferences matter. So you can ask a young person, what would you want to do when you're 65 years old? Or you could ask the 65-year-old, and they would give you different ratings of quality of life or happiness. And as a policy decision maker, which framing is better, to use the population average or a younger cohort, or just the people who are vulnerable for this procedure or disease?
Okay, yeah, well, this is certainly a question that comes up all the time, whose preferences. So if we're doing a choice experiment, who are we going to elicit the preferences for? And I guess economics talks about individual preferences, but who's the individual? I think what we need to be is justify what stance we take. So some people will argue, if we're looking at questions more of allocative efficiency or the principles of our health service, then we should ask the public because it's their money we're spending. If we're looking at the more individual level about how should we provide heart surgery or cancer treatment, then ask patients in that situation because they better understand. And if the general public were to be in that situation, they would probably have preferences like that. So yeah, I don't think there's an absolute answer. I think following on from that, the question is also whose perspective. Am I giving my preferences as an individual or as a member of society?
Okay. Pierre?
Well, we are living in a, sorry, in a composite country. And I was wondering whether you have data concerning ethnic discrete choice preferences, because that would be quite important in terms of global health in a country like us where we have a lot of immigrants, or even if they are second generation immigrants. So is there any data on which we could rely?
Okay, so in most preference elicitation tasks, whether it's choice experiments, contingent valuation, qualis, people would collect socio-economic data and other data and then look at heterogeneity of preferences. So within DCEs done within communities that are diverse, I would imagine that data is there, although I couldn't recall any of the results.
Okay, Alberto.
Yeah, so I enjoyed very much the presentations, and I would like to ask an impertinent question, which is related to some of the issues which were presented in the presentations. I very much like the attribute type of decision, but I was wondering what is the difference, and why wouldn't you not continue to do hedonic regression based on observations? Mattéo said that in fact we have a lot of observation, we have a number of data that we can use to do hedonic regression, which is in the 80s or 90s quite popular, and in particular in health economics we use it for drugs and to evaluate the attributes of drugs. So of course the answer would be that these observational data do not take into account the constraints which are faced by people when they make the choice. But the issue, so the question is, how do you properly take into account the constraint when you do a choice experiment? So in fact, I have these two questions, which is, why don't you use observational data and with a larger population and avoid some of the difficulties related to a choice experiment like bias, hypothetical bias, and so on?
Okay,
And,
so actually, I think a key response to that is we often don't have the data. So there is increasingly in health economics, and particularly in the UK, this move towards secondary data sets and linked data and using existing data. But actually, we don't have the data. For instance, if a drug company are thinking of introducing a new drug, well, the drug doesn't exist. If we're looking at how can we increase the uptake of a new lifestyle intervention, it doesn't exist yet. So actually, I think health economists have almost been forced down the road of stated preference because there's very limited choice data. But the other, I think an important response also is even where revealed preference data exists, it may not be the best data. So one of the great things about a discrete choice experiment is you set up the data matrix, you decide the choices, you overcome any problem of multicollinearity and not being able to identify what's causing the problem. And where choice data does exist, actual choice data, I think the movement is more to looking at how the two can work together rather than looking at them up in opposition.
Just a comment on the fact that some objects do not exist, and you have to look at them because you don't have data. But in fact, many economists made fortune by valuing new products based on existing attributes and valuation of the different attributes. So the fact that there is something which is new, which does not exist, you can still evaluate it through the attributes.
If the new product is a new combination of existing attributes, for instance. So, Liz.
Well, thank you very much for all the speakers. That was fascinating. I have a question relating to Andrew's example where he says that smokers are happier when the prices increase because in many ways it ties their hands and it helps them sort of fulfill their meta preferences. I think that ties back to Nicolas' point about commitment. And I just wanted to ask Nicolas whether he could give us an example of how he could use some of the work he's done on commitment and revelation of preferences through commitment. You just said that it enhances the trustworthiness of the responses. How would you translate the work you've done in health economics?
So the way we improve the truthfulness of responses in our discrete choice experiment is essentially by implementing to the survey the court institution through which people swear to tell the truth when providing answer during the survey. And what we show is that this particular device does improve the truthfulness of answers that we elicit. And what is interesting about this is that in a sense, this tells us two different things. First of all, this tells us why the sincerity of responses improve. And this is because of a lack of commitment towards truthfulness, which means we need to account for truthfulness when designing this kind of surveys. And the second thing is it's really easy to implement in the field. So you can have people actually swear that they will tell the truth or obtain from them some statement about the truthfulness of their answers. And what our results show is that this should improve the reliability of the answers.
Daniel?
So one of the key points when doing stated preference analysis is to try to validate that your preferences are correctly elicited. So I was wondering, so what would you do with those individuals whom the test did not pass? So should we take them out? And if so, if you're going to use the preferences for those individuals whom you left in, do you think that those are capturing the preferences for those that you left out? And in particular in health, that's quite important because we know that the outliers in the health system are those ones that are leading the expenditures in health. So I was wondering, what would you say?
Okay, so that's, I think, a question that many health economists face when doing a choice experiment. The standard practice has been to include tests of internal validity in the absence of having external validity. So do people satisfy the axiom of dominance? Do they always choose better choices? Are they transitive? And then the question is, well, if they fail it, do you leave them out or do you include them? And I think at one point they used to be left out. The argument for including them is actually random utility theory, the framework of analysis, allows for random error. The question then becomes, is it random error, or are these people systematically not really engaging in the exercise? And then, of course, you've also got the people who continually choose to opt out. And quite often those people will be excluded, when actually they're actually a really important group, because they're saying, actually, I'm not willing to trade amongst all these attributes. I'm always going to, for example, do what I currently do. Well, that's actually really important from a policy point of view, but actually it might not be appropriate to analyse within a choice experiment framework because they're not trading.
Maybe adding on that one quickly. I think we in behavioral experiment where we elicit fundamental preferences like risk preferences, time preferences, social preferences, we usually learn quite a lot from the subject that are actually inconsistent. Actually, you can classify people according to different type of inconsistencies. So the subject that give answer responses that contradict one to the other, or the inconsistent in the behavioral economic sense, so that actually taking inconsistency preferences once presented twice. And for instance, you can model the inconsistent, so you can use those inconsistent subjects to predict a range of health behavior, suboptimal health behavior, and that categorization is quite good in predicting suboptimal health behavior. And another thing you can do is using the response times, which are also very informative to categorize the different type of inconsistency. So I would not throw them out, personally.
So there's consistent ways to be inconsistent. That's good news for economists. It's and maybe one question that I had, which may be the introduction to the break, is what strikes me is, you know, as economists we keep talking about preferences, about choices, about consumption, and when we talk with other scholars about health and healthcare, the first word that comes to mouth is talking about needs. Okay, no one mentioned that word. So, and of course, it's for economists talking about needs is something we're uncomfortable with that. And I checked in most micro textbooks. There's no entry for need. Okay, so we don't really know. It's an ill-defined thing. Why? Because we want to insist on trade-offs. So if there's things like needs, then there's no trade-offs. So then we're out of business, and we have to pass the floor to other scholars, and we usually don't like to do that. So, so this just a reflection. Are these tools? Could these tools be useful to think about and to elicit needs, or is it typically not a good answer? That's the first thing. The second thing I wanted to say is that there's going to be more on that subject tomorrow morning for the workshop. So please join the workshop tomorrow. The discussion will continue, and this maybe also thanks to all the presenters and thanks to all the questions Now, maybe an introduction to the next panel. It's at some point, I think, Mandy, you referred to that saying that there's lots of criticisms about qualities, and we are now lots of research about going beyond qualities, and this work is certainly very important, and certainly some of that questions are also done at the Ospinomics, and the question is, giving the impression that qualities are not, for us, we know that qualities are not perfect. You know, they're not the perfect tool. But now if we want to think about which tools should be used by policymakers, saying that qualities are not the best thing may be a little bit dangerous, because then a reaction may be, okay, qualities are not good, so let us continue doing as before, with not taking into account costs and prioritizing according to other rules. And so Well, as you know, in a cost-benefit analysis of you know, using qualities as imperfect as they are as of today, would that be better to use them now or to wait until we have better tools than qualities? So. That looks like, it doesn't look like a question, but it is a question.
Yeah, I mean, I think that we're certainly not suggesting we go back to pre-quali days and decisions being made randomly, but or by doctors. But what we do need is an alternative framework. And actually, it's not so much the quali, you might say, has limitations, but the 5 dimensions of the quali. So you might see a capabilities type framework, which is being developed in health economics, which is actually very similar to the quali, only the dimensions you're using are more to do with sense capability framework than physical functioning. But I think you're absolutely right. What we need to do is look at alternative decision-making models that can inform decision makers. And I think in terms of the research in academia and choice experiments, so there's the methodological work, which we'll look at tomorrow, but there's quite an industry of research looking at incorporating willingness to pay and choice experiments into economic modelling. And in fact, using all the developments we've made in economic evaluation over the last 20 years in modelling frameworks, discrete event simulation and various others, but looking at how we can have broader measures of value beyond beyond EQ5D in there. But unfortunately, I can't speak French, so I won't be at the next session.
Okay, well, again, thanks a lot. Thanks to all the speakers. And I don't know what need is, but I know we need a break.